problems, how do we assess them, how do we manage them. So infertility affects 1 in 7 heterosexual couples, and there is a small increase in the prevalence of fertility problems, and a greater proportion of people now they're seeking help for such problems. Why? Because the awareness is spreading, so if there is a solution, people really like to benefit from it. And the main causes of infertility are unexplained, like we didn't find any male or female cause. Previously, it was said to be the incidence was 25%, but then amendment was made that it is almost 30 to 40%. Ovulatory disorders, 30%. Tubal damage, 20%. Factors in the male causing infertility, 30%. Uterine or the peritoneal disease, 10%. So in about 40% of the cases, the disorders are not found in both. The disorders are found in both the men and women, like in 40%. So that is the mixed up disorder. So uterine or the emotional, like the emotional factors, gamete or the embryo, and the pelvic conditions such as endometriosis, all of these can play a role, which right now we are not in a position to quantify, but it is speculated that there can be disorders of the endometrium, like implantation is improper, could be immunological disorders, could be some problems in the gamete embryo, and the pelvic conditions such as endometriosis. They all have a role to play, but how much we have not been able to quantify. So the investigations we need to do are Siemens Analysis, assessment of ovulation, tubal damage, uterine abnormalities, and we also need to screen for STIs like chlamydia trachomatis and susceptibility to rubella infection. So once a diagnosis has been established, treatment to restore fertility, it will fall into three main types. Like we can give medical treatment, for example, by the use of drugs for ovulation induction. This is called like controlled ovarian stimulation. Surgical treatment, for example, laparoscopy for ablation of endometriosis. Then assisted reproductive techniques like ARDs. So any treatment that deals with means of conception other than vaginal intercourse, it is called assisted reproductive technique.
Yeah.
Like things are not occurring in a natural manner. So it frequently involves the handling of gametes or embryos. There are certain important issues for discussion, like in unexplained infertility. Expectant management increases the cumulative chances of successful conception. Most important determinant of fertility is age of women. That is also SBA. The age of women is the most important determinant of their fertility. Live birth, both by natural conception and by using ART, they decline with advancing age because of a woman's decreasing ovarian reserve. A shorter period of expectant management for women who are 36 or older should be adopted. In current IVF practice, it is common to transfer more than one embryo in order to maximize the chance of pregnancy. Further research is needed to assess the efficacy of adjuvant luteal phase 4 treatments such as low-dose aspirin, heparin, prednisolone, immunoglobulins, and/or fat emulsions. It is safe to undergo ovulation induction and ovarian stimulation. These interventions they will not lead to significant long-term health issues, especially ovarian malignancy. Both IVF and ICSI they involve manipulation of egg and sperms in the lab with impact on the development of the subsequent embryos. Because we are doing it outside the body, even so there can be damage to the zona pellucida. There can be changes in the sperms in the ovum, which right now maybe we don't have the capacity to assess. Regarding principles of care, we need to provide good information. So see the infertile couples together because both partners are affected by decisions surrounding the investigation and treatment. People should make informed decisions via access to the evidence-based information, and information should be provided in a very easy format to people so that if they have like additional needs, like the people they have cognitive, physical or sensory disabilities, And then if they have a language barrier, like they don't understand English, so we need to address their needs. Regarding psychological effect, stress in the male and or the female partner, it can affect the couple's relationship and is likely to reduce libido and frequency of intercourse, which can contribute to the fertility problems. It is helpful to contact a fertility support group, and counseling should be offered before, during, and after investigations of the treatment, irrespective of the outcome of the treatment. Counseling should be provided by someone who is not directly involved in their management. There are like generalists and the specialist care. A specialist team should provide care because it is likely to improve the effectiveness and efficacy of treatment and people's satisfaction with treatment. Initial advice to couples concerned about delays in the conception is that over 80% of the couples in the general population, they will conceive within 1 year if the woman is aged under 40 and they don't use any contraception and they have regular sexual intercourse. Of those who do not conceive in the next year, about half of them they will do so in the second year, like the cumulative rates after 2 years of trying are going to be over 90%. With artificial insemination, over 50% of the women who are less than 40 years, they will conceive within 6 years of intrauterine insemination.
Sorry, this with the
Among remaining about half, they will do so with a further 6 cycles, so the success rate is over 75%. So using fresh sperm, then conception rates are higher than the frozen thawed sperm. So better to use the fresh sperms. Intrauterine insemination with frozen and the thawed sperms is associated with higher conception rates than the intracervical insemination. Fertility that the female fertility and to a lesser extent the male, it declines with age. Frequency and timing of the sexual intercourse or the artificial insemination. So vaginal sexual intercourse should take place every 2 to 3 days, optimizing the chance of pregnancy, and insemination should be timed around ovulation. Alcohol, like women who are drinking 1 or 2 units of alcohol once or twice per week and avoiding episodes of intoxication, it reduces the risk of harming a developing fetus. Men who are taking 3 to 4 units per day unlikely to affect their semen quality. Smoke is likely to reduce their fertility, especially the sperm motility. There is an association between smoking and reduced semen quality, although the impact of this on the male fertility is uncertain. And that stopping smoking, it will improve their general health. No consistent evidence of an association between consumption of the caffeinated beverages like the tea, coffee, and colas and the fertility problems. Obesity, it plays an important role. Obesity is, so women with a BMI greater than 30, they are likely to take longer to conceive. Losing weight is likely to increase their chance of conception. Low body weight, that women with BMI less than the 19 with irregular menstruation or who are not menstruating, they should be increasing body weight to improve the chance of conception. That is if their BMI is less than 19. Obesity when their BMI is more than 30, and here the BMI is less than 19. Wearing tight underwears, and they will elevate scrotal temperature by 1 degree, and generally the scrotal temperature is kept 2 degree lower than the rest of the body. That is important, right? So it is not known that wearing the tight underwears it causes any problem or it doesn't, but better that they should wear something like wearing the loose fitting underwear. It improves fertility. So till now we don't have like good evidence for it. Okay, so we can't comment on it. Occupation. A specific inquiry should be on occupation of the patient and her husband because maybe they are being exposed to the environmental hazards. Then prescribed over-the-counter drugs and what will be their effect? Number of prescriptions over the counter and the recreation drugs, they interfere with the male and the female fertility. and a specific inquiry about these should be made and appropriate advice should be offered. Regarding contemporary therapies, the effectiveness of the complementary therapies for fertility problems, it has not been properly evaluated. Folic acid supplementation, dietary supplementation with folic acid before conception and up to 12 weeks gestation, it reduces the risk of having a baby with neural tube defects. The recommended dose is 0.4 milligrams per day. A higher dose of 5 mg per day is recommended for women who have previously had an infant with neural tube defect, and then the women who are taking anti-epileptic medication and in diabetes, and if they are having any malabsorption, they can ask you questions around many things. If they have like chronic disease, or they have like their age is more than 40, then again they should be taking 5 mg folic acid. Hemoglobinopathies, right? So in some medical disorders, they need to take higher dose. And
Folic, yeah.
hemoglobinopathies, both like thalassemia and the sickle cell disease, are included in it. So then at the initial assessment, we should ask a specific inquiry about lifestyle, about their sexual history, their habits, and at what time of the cycle they are doing it, and how frequently they are doing it, what are their sexual practices, everything should be asked. So discuss the options for attempting conception. So around conception to people who are unable to or would find it difficult to have a vaginal intercourse. Maybe they have like some structural, defect, some phobias. So many things can be there. Okay, it could be physical or psychological limitations. We need to address it. Like I will give you one example. Like we had a patient whose BMI was like 70. So even for intercourse to happen, somebody had to hold her thighs so that the husband will enter. So we need to explore
Oh
in
my
depth
God.
that what exactly she needs, okay? Hindrance. So the environment should enable people to discuss sensitive issues such as sexual abuse. A woman not conceiving within 1 year of unprotected vaginal intercourse, in the absence of any known cause of infertility, the clinical assessment and investigations with her partner, they should be arranged. We should offer an earlier referral for the specialist if the woman is aged 36 years or over. There is a known etiology or a history of predisposing factors for infertility. Where anti-cancer treatment is planned, and the result is it may result in the infertility. Like the patient is going to receive cyclophosphamide. So before starting the treatment, we have to set an appointment with a fertility specialist. People with chronic viral infections such as hepatitis B, Hep C, or HIV, they should be referred to their centers with appropriate expertise and facilities to provide safe risk reduction, investigation, and treatment. Investigations of the fertility problems and management strategies. Semen analysis. The result of semen analysis conducted as part of the initial assessment should be compared with the following. WHO reference values, like the semen volume should be more than 1.5 ml. It should be at least 1.5 ml. pH should be 7.2 or more, and the sperm concentration should be 15 million spermatozoa per ml or more, and then the total sperm number, it should be like 39 million spermatozoa per ejaculate or more. Total motility, like the percentage of the progressive motility and the non-progressive motility, like they should be 40% or motile or 32% or more with progressive motility. Vitality should be 58% or more live spermatozoa. Sperm morphology, like the percentage of the normal forms, should be 4% or more. So screening for anti-sperm antibodies, it should not be offered because there is no evidence of effective treatment to improve fertility. If the result of the first semen analysis is abnormal, we should repeat the confirmatory test.
Sorry, which one
Should
is
be
more
offered.
important? Is it? Sorry.
So they can ask you that when are you going to repeat the semen analysis. So if the result of the first semen analysis is abnormal, a repeat confirmatory test should be offered. Repeat confirmatory test 3 months after the initial analysis to allow time for the cycle of spermatozoa formation to be completed. So, however, if raw spermatozoa abnormality or the deficiency is seen like azoospermia or severe oligozoospermia, then we have to ask them to take the test again as soon as possible. Under which conditions? If there is azoospermia or severe oligozoospermia. Why? Because we want to see that this patient is ever going to benefit with the IVF treatment, or we need to send them for straight away for the surgical retrieval. That is the point, okay? Because time is of essence. So, and what are the simple abnormalities? If one of the parameters is abnormal, then we say that sperm parameters are not met. But if two parameters are abnormal, then we say that there are severe deficits. That is the point, okay? So, post-coital testing of the cervical mucus is not recommended. So, you have done the semen analysis, that is the initial workup. So then you need to see that the woman is passing the egg or she is not. So how we can check this one, the ovarian function? What do we do for it? Yeah, so we can actually do different things to see the ovarian result. So use a woman's age as initial predictor of the success through the natural conception or with the IVF. So we can use one of the following measurements to predict that the likelihood of the what would be the likely response of the woman to the GnRH stimulation. Why GnRH stimulation is important? What do you think about it? Because GnRH stimulation, it is going to stimulate the ovaries. GnRH is coming from the hypothalamus. So it will come from the hypothalamus. It will affect on the anterior pituitary, cause release of luteinizing hormone and the follicle stimulating hormone. And after that, these agents, these are gonadotropes, okay? They will go to the ovary and they will cause release of estrogen progesterone. Right? So if they, so we need to give them GnRH, okay? So we want to give them GnRH or some, but in practice mostly we are giving them FSH, right? So we want to see, we want to predict what will happen, her response will improve if we will give her GnRH stimulation or not. So how do we assess the woman? We need to take this total antral follicle count. If it is less than 4, like in the antral stage of the cycle, we will see that how many follicles are there in her ovary. So if they are less than 4, so it means that the response will be poor, low response. And if we see more than 16 follicular antral follicles, then it means the response is going to be good. Then we check the anti-Mullerian hormone. If it is less than or equal to 5.4 picomole, then the response is going to be low, and if it is more than 25, then the response is going to be high. Then the third thing is follicle stimulating hormone. If it is greater than 8.9, then international units per liter, then the response is going to be low. And if it is less than 4 international units per high, then the response is going to be better, high response. And then we don't have to use the following tests to determine the outcome of the fertility treatment, like ovarian volume, ovarian blood flow, inhibin, estradiol. Actually, these things have been used in the past, but now with the emergence of the knowledge and the evidence, we have seen that these interventions are not very helpful, okay? So after assessing the reserve, then we have to look at the regularity of the menstrual cycle. So we will ask about the frequency and the regularity of their menstrual cycle, and the women with the regular monthly cycle, they are more likely to be ovulating. So the women, they should be offered a blood test to measure serum progesterone in the mid-luteal phase of their cycle, like from day 21 or day 28 day cycle, to confirm ovulation even if they have regular menstrual cycle. Women with prolonged irregular menstrual cycle, they should have a blood test to measure serum progesterone. This test, it may need to be conducted later in the cycle, for example, and you know that ovulation will take place 14 days before the start of the menses. If a woman is like here she has 28-day cycle. So we are testing it for when is she likely to ovulate. She is likely to ovulate like 14 days uh, before the expected time of the menstruation. Similarly, if she has like 35-day cycle, then she is very likely to ovulate for 35 minus 14 on day 21 of the cycle. Okay, so here we have to test her serum level like 2 weeks after the ovulation. So in that case, and then 1 week before the onset of menses. So we need to check the serum progesterone. So serum progesterone should be more than 3 nanograms. If the serum progesterone is more than 3 nanograms, then it means that she is going to ovulate or she has ovulated like in the previous cycle. If her cycle is that of 35 days, then you are going to test the serum progesterone at 28 days of the cycle. And then after that, so we are
Say
going to
again,
test.
sorry, regarding the progesterone on the 28th
Yeah,
day.
yeah. If she has a regular cycle of 28 days, then on the
Mm,
day 21 of the cycle, we are
yeah,
going to test the serum progesterone
serum.
level. Okay?
Yes, yeah.
And if she has like 35-day cycle, then we are going to test like at 28 day of the cycle. Why? Because ovulation must have like the conception must have
2
occurred
weeks.
or ovulation has occurred. Okay? Ovulation has occurred,
Oh,
so we are going to test 1 week before the expected day of onset of the menses. Is it clear?
mhm. Yes, yeah, now clear, yeah.
And pay attention to this point. If they ask you that when she's going to ovulate, so she has 28-day cycle, you will say 28 minus 14, you will say on day 14 of the cycle. Okay. And if she has a long
Mhm,
period like 35, then you will say that 35 minus 14, that on day 21 she is likely to ovulate. Okay,
mhm,
because the follicular, because this phase, the luteal phase is fixed. Like we have two halves of a cycle, the luteal phase, the follicular phase and the luteal phase. So the
mhm,
follicular phase, that is like can be non-fixed, can be variable, but the luteal phase is going to be fixed, that is 14 days. Why? Because the progesterone is more reliable. Okay,
mhm,
that
yeah.
is one thing. Okay, so we are going to test the ovulation in the 14 days before the onset of the cycle. Okay, and if you want to test the serum progesterone, then you will test it 7 days before the expected day of the starting a new menstrual cycle. That is it. Okay, so then the use of the basal body temperature, it should not be done like that. Okay, so if there is a person like this may not need to be conducted later in the cycle and repeated weekly thereafter until the next menstrual cycle starts. Like the patient doesn't have even, like she has very irregular cycles, so then what we will do? Then we will start after 14 days and every week, like you will say that okay, this is the day 14. So after that, you will start measuring her cycles. Like every week, you are going to test her serum progesterone level to see that
Progesterone.
she is passing egg or she is not passing. That is one thing. Okay. So
So
using,
this will be after 2 weeks from the period.
yeah,
Then I'll start measuring
yeah, yeah, you
every
will,
week.
yeah. So you
Mhm,
will offer her a withdrawal bleed because she has grossly irregular cycles. Okay. And then
mhm,
after 2 weeks, after that, you will start measuring her serum progesterone on weekly basis. Okay, unless you
mhm,
find that there is a rise or if there is a plateauing or she is going to, or she is having, or she starts her cycle. But that is subspecialty subject. Okay, so they are not going to ask you.
mhm.
They will ask you only about the
Okay.
ovulation and about the this testing, that when are you going to test the serum progesterone level. That is one thing. Okay. So basal body temperature, it should not be used. Like many kits are based on it, like Persona and other kits, but it should not be used because it is not highly reliable, because they see that when the progesterone is there, it is going to increase the body temperature by like half degree centigrade. So high progesterone level means that the patient has already ovulated. That is the point. Okay.
Mhm, yeah.
So the prolactin measurement. So we should not be offering the blood test to measure the serum prolactin unless if the as a detection of the you should it should not be offered routinely. But if you are suspecting that she has some ovulatory disorder, she has some galactorrhea, or she has some tumor, then we need to check the prolactin level. It is not part of the routine checkup. Thyroid function test, then measurement of the thyroid function, it should not be offered, and estimation of the thyroid function should be confined to the woman with symptoms of thyroid disease. So here also symptoms of prolactin disease investigate. Here also the thyroid, then if the symptoms are there, only then you need to check the patient, otherwise no need. Endometrial biopsy, it should not be offered because there is no evidence that the menstrual treatment of the luteal phase defects, it will improve the pregnancy rate, so no need to do it. So then intervention, because endometrial biopsy, some people I have seen them that they used to do this small scraping on the uterine cavity, but that is not beneficial, should not be done. Then investigations of the suspected tubal and the uterine abnormalities. Women who are not known to have comorbidities such as the PID, previous ectopic pregnancy, or endometriosis, they should be offered hysterosalpingography to screen for tubal occlusion. Like maybe when we can also offer saline infusion sonohysterography, or we can do fertiloscopy. So fertiloscopy involves, like, we are looking at the uterus. So we are looking at the tubes, and then we are looking at the posterior, like the pelvic peritoneal cavity also. Why? Because we want to see that the tubes are fine. We are looking into the tube, and we are looking into the uterus, and then the back of the uterus, that there are no adhesions. That is fertiloscopy. So we can do hysteroscopy, falloposcopy, and then we are looking into the peritoneal cavity, that there are no adhesions in the pouch of Douglas. So then contrast ultrasonography, it should be considered because it is an effective alternative to hysterosalpingography for women who are not known to have comorbidities. Women known to have comorbidities, they should be offered laparoscopy and dye so that tubal and the other pelvic pathology, it can be seen. Then women they should not be offered hysteroscopy in initial investigation unless clinically indicated, because the effectiveness of the surgical treatment of the uterine cavity abnormalities on improving the pregnancy rates, it has not been established. Then we need to test the viral status of the woman. We need to test her for the hepatitis B, C, and if something is positive, HIV, then we need to send them to the virologist. Regarding viral transmission for couples where the man is HIV positive, then MDT of HIV, like the specialists, fertility specialists in the couple, they should have discussion on the treatment options. And we will advise couples where the man is HIV positive that the risk of HIV transmission to the female partner is negligible in unprotected sexual intercourse. So then, if all of the following criteria are met, like the man is complying with highly active antiretroviral therapy, and the man has had plasma viral load less than 50 copies per ml for more than 6 months, and there are no other infections present, and unprotected sexual intercourse is limited to the time of ovulation. If all of these things are taking place, then the chance of getting infection is negligible. For couples where the man is not compliant with HART, or his plasma viral load is 50 copies per ml or greater, then we need to offer sperm washing. But now, they are not even offering sperm washing, because they said that the chance of transmission of infection with each sexual active is just 0.03%, but they didn't change in the guidelines, so we are reading it. That is the point.
Okay.
Yeah, so if couple still perceives an unacceptable risk of HIV transmission after discussion with their HIV specialist, then we should consider sperm washing. HIV negative women, they should not use pre-exposure prophylaxis when all the criteria in the given in above, they are met. For parents of the partners of the people with hepatitis B, we should offer vaccination before starting fertility treatment. Don't offer sperm washing as part of the fertility workup for men with hepatitis B. And if the man has hepatitis C, any decision about fertility management, it should be made after discussion between the couple, the fertility specialist, and a hepatitis specialist. If the man has hepatitis C, the risk of transmission through the unprotected sexual intercourse is thought to be low. Susceptibility to rubella, we should offer testing for the rubella status so that those who are susceptible to rubella, they can be offered vaccination and advised not to become pregnant for at least 1 month following vaccination. Cervical cancer screening to avoid delay in the fertility treatment. Specifically, we should ask about timing and result of the most recent cervical smear test. Screening for the chlamydia trachomatis, then before undergoing the uterine instrumentation, we should offer screening for the chlamydia trachomatis and use an appropriately sensitive technique. If positive for chlamydia trachomatis, then women and their sexual partners, they should be referred for appropriate management with treatment and contact tracing. Administer prophylactic antibiotics where instrumentation is required if the screening has not been carried out. Medical and the surgical treatment of the male factor fertility problems. So, medical management for the male factor infertility. Men with hypogonadotrophic hypogonadism, they should be offered gonadotropin drugs because these are effective in improving fertility. Men with idiopathic semen abnormalities, they should not be offered anti-estrogens and the gonadotropins, androgens, bromocriptine or kinin enhancing drugs because they have not been shown to be effective. The significance of anti-sperm antibodies is unclear and the effectiveness of systemic corticosteroids is uncertain. Men with leukocytes in their semen, they should not be offered antibiotic treatments unless there is an identified infection because there is no evidence that this improves pregnancy rates. Surgical management of the male factor. If appropriate expertise is available, men with obstructive azoospermia, they should be offered surgical correction of the epididymal blockage because it is likely to restore patency of the duct and improve fertility. Surgical correction, it should be considered as an alternative to surgical sperm recovery and IVF. Men should not be offered surgery for varicocele as a form of fertility treatment because it doesn't improve pregnancy rates. Management of the ejaculatory failure. Treatment of ejaculatory failure, it can restore fertility without any requirement of invasive procedure of the sperm retrieval or the use of assisted reproductive technology.
What question can they bring regarding the male fertility, apart from?
So if there is ejaculatory failure, then again we need to restore fertility without invasive procedures for the sperm retrieval or the use of ART. So for all of these things, you need to refer the patient to the urologist for surgical sperm retrieval, which they can do through the testis or they can do it through the epididymis, as the facility is available and as per the condition of the person. Okay.
Yeah.
So then going to the female side, there can be ovulation disorders, we classify them according to the WHO classification grid, and it is divided into three groups: group 1, group 2, group 3. In the group 1, there is hypothalamic pituitary failure, like there is hypothalamic amenorrhea or hypogonadotrophic hypogonadism, like the GnRH is very low and GnRH is low, so there will be decreased level of the FSH and LH, and it will make up our group 1 hypothalamic pituitary failure, that is failure. Group 2, hypothalamic pituitary ovarian dysfunction. Okay, so what happens? Mostly the levels, they are not working properly. So the levels could be higher, but the whole thing is not working in the regular way. Third type of disorders, they can be due to ovarian failure. So in ovarian failure, you're going to find a very high level of the FSH, like more than 35 international units. That is the problem, okay? So in the WHO group 1 ovulation disorder, we should advise women that they can improve their chance of regular ovulation, conception, and uncomplicated pregnancy by increasing their body weight if they have a BMI of less than 19, and or moderating their exercise level if they undertake high level of exercise. Then offer women with WHO group 1 ovulation disorder, we will offer pulsatile administration of gonadotropin releasing hormone or gonadotropins with luteinizing hormone to induce ovulation. If they fall under group 2 of the WHO ovulatory disorders, we will advise them that if their BMI is more than 30 or over, to lose weight, and inform them that this alone may restore their ovulation and improve their response to the ovulation induction agents and have a positive impact on the pregnancy outcomes. Offer one of the following management options, treatments, and taking into account potential adverse effects, ease, and mode of use of the woman's BMI and monitoring needed, like the clomiphene citrate or metformin or a combination of the above. So for women who are taking clomiphene citrate, we should offer ultrasound monitoring during at least the first cycle of treatment to ensure that they are taking a dose that minimizes the risk of multiple pregnancy. For women who are taking clomiphene citrate, they should not continue treatment for longer than 6 months. Women prescribed metformin, they should be informed of the side effects associated with its use, such as nausea, vomiting, and other gastrointestinal disturbances. In women with WHO group 2 ovulatory disorder who are known to be resistant to clomiphene citrate, consider one of the second line treatments depending on clinical circumstances and the woman's preference. These treatments can be laparoscopic ovarian drilling or combined treatment with clomiphene citrate and metformin. If they have not already been given, or if they decline to take this clomiphene citrate and metformin, then the way forward is to give them gonadotropins. So gonadotropins, they are going to stimulate, because if you will give them clomiphene citrate, it will also act through its action. This is a sperm selective estrogen receptor modulator, so it is going to exert its effects through the action of the hypothalamus and thalamus. Hypothalamus and the anterior pituitary, and the gonadotropins, they will exert their actions through hypothalamus, because hypothalamus will produce gonadotropin releasing hormone, and they will produce their action through these gonadotropins. They will have effect on the pituitary.
Okay.
And this clomiphene citrate will have effect on the hypothalamus. That is the thing. And the metformin is going to have its effect on the peripheral tissues, because it is going to sensitize them to the insulin, and insulin, it will control the LH surge. So if the LH surge is controlled, then your patient is going to ovulate. Like the surge is generated, because in the patient with the PCOS, like it has come here, the problem is that the LH is maintained at a stable basal level. Okay, so the insulin is going to enter the ovaries, decrease the level and the level of this LH, and after that the body will go into a normal mode, and only then we can generate. Only if the level will go low, then it can increase, because otherwise if it is staying at a higher level, there will be no LH surge. No LH surge, so no ovulation will take place. That is the point. Okay,
so in type 1, the FSH and LH, what is the ratio?
In type 1 ovulatory disorder, you are going to see very low levels, like they will be less than 1 international unit. Could be like 0.1, 0.01, okay? So in the type 1
the FSH and LH.
yeah, FSH, LH, they will be very low in type 1 ovulatory disorder. In the type 2 disorder, they can be like the LH can be high, can be low, like that. Okay, so it can be
high
even
or
normal.
low, okay.
Like in the case in the classification of the PCOS, When we are talking about PCOS, before we used to say that LH will be elevated almost doubly as
Yeah.
compared to the FSH, but then it was removed from the definition, right?
Yeah.
Because even in the people with absolutely normal levels of the FSH and LH, the PCOS can occur, right? So, why are we doing any investigation? We do a certain investigation because we expect to find some answer. Okay, so that is useless. That's why the ratio is not important, because the estradiol, LH, FSH, they all can be normal in the patients with the PCOS. So in type 1 ovulatory disorder, the gonadotroph level is going to be low. Okay, and in the second type, like the group 2, it can be normal or it can be abnormal. But mostly it will be like, even if it is abnormal, it will be very close to the normal. Even if it is abnormal, it will be close to the normal values. That is the point. So women
Okay.
with PCOS being treated with the gonadotrophs, they should not be offered treatment with the gonadotropin releasing hormone agonist concomitantly, because it doesn't improve pregnancy rate, and it is associated with an increased risk of ovarian hyperstimulation. The use of adjuvant growth hormone treatment with gonadotropin releasing hormone agonist and or human menopausal gonadotropin during ovulation induction in the woman with the PCOS who do not respond to the clomiphene secrete is not recommended, because it doesn't improve pregnancy rates. The effectiveness of the pulsatile GnRH releasing hormone in women with a clomiphene secrete resistant polycystic ovary syndrome is uncertain, so it should not be given. So when you will say that the patient is resistant to clomiphene, you will say so when you have given clomiphene citrate for 3 cycles and the patient has not ovulated, or there is no proof of enlargement of the follicles on ultrasound. Then you will say that this patient is resistant to clomiphene citrate. The incidence is like 11%. So if after 3 months there is no evidence that this woman, what will be the evidence? You will measure the serum progesterone level, right? So if the serum progesterone level is less than 3 nanograms, then you can say that this patient has not ovulated like that. Okay. So sometimes they are writing 30 mg per dl, sometimes writing 3 nanograms per liter. So all of these are correct. Don't worry about them. Only the U rate is changing. Okay.
Sorry, the only what?
Unit. Like it is
The unit.
how many units per deciliter or how many units per liter of the plasma of the woman. Okay, that is the point. Okay, so hyperprolactinemic amenorrhea. So women with ovulatory disorder due to hyperprolactinemia, they should be offered treatment with dopamine agonist such as bromocriptine, and consideration should be given to the safety for use in pregnancy and minimizing the cost when prescribing, because the patient, if they have very high level of the prolactin, it means that their level of the gonadotropin releasing hormone is very low. So we need to give them dopamine agonists, because by dopamine agonist, it means that we are going to give some substances which will act like dopamine and they will inhibit production of prolactin. That is the point. Okay. So then monitoring ovulation induction during gonadotropin therapy. So women who are offered ovulation induction with gonadotropins, they should be informed about the risk of multiple pregnancy and ovarian hyperstimulation before starting treatment. Ovarian ultrasound monitoring to measure follicular size and number, it should be an integral part of the gonadotropin therapy to reduce the risk of multiple pregnancy and ovarian hyperstimulation. So tubal and the uterine surgery. Tubal microsurgery and the laparoscopic tubal surgery, what should be done? So for women with mild tubal disease, the tubal surgery, it may be more effective than no treatment. And in centers where appropriate expertise is available, it may be considered as a treatment option, like microsurgery of the tube. Tubal catheterization or cannulation. So for women with the proximal tubal obstruction, selective circumgeography and plus tubal catheterization or hysteroscopic tubal cannulation. It may be the treatment option because these treatments they improve the chance of pregnancy. Surgery for hydrocephalus before IVF treatment. So women with the hydrocephalus should be offered salpingectomy and preferably by laparoscopy before IVF treatment because this improves the chance of a live birth. Uterine surgery. Women with amenorrhea who are found to have intrauterine adhesions, they should be offered hysteroscopic adhesiolysis because this is likely to restore menstruation and improve the chance of pregnancy. Medical and the surgical management of endometriosis, it should be offered. Now, as you know that there is no role of medical treatment of endometriosis, we have to do surgical excision of all deposits. That is important, okay? Biologics, some immunotherapies, they are being used, but still we don't know because the college has not made any recommendation about it because endometriosis is considered an immunological disorder. Okay.
There are few questions which they say
or because each conception will not result in a live birth. There can be like maybe the baby developed up to the age of 3 months and then it was aborted, or there was preterm birth, like the baby was not viable. So many things. So regarding the GnRH, it will cause twinning in like 20% of the patients, and clomiphene citrate, it can cause twinning in like 5 to 10% of the patients. But then the point is that all of these ova which are released, they are not going to yield a full live birth. Okay, so the live birth rates are very low. Like if we say that for the clomiphene citrate, like it will cause ovulation like 80%, but if we will look at the live birth rate, maybe it will be just 50 to 60%. Similarly, if you are giving the GnRH analog, then the chances of ovulation are higher, like 70 to 80%, but the chances of getting a live birth, they will again be like 60 to 70%. That is the point. So that is the difference. So there are like no set numbers. These are just ideas and assumptions that because derived from many studies like that. That is the point. Does that answer your question?
Do we need to know certain type, which type, like whether the clomiphene citrate or the gonadotrophin, which one cause live birth, which one cause spontaneous?
Yeah, they both will cause, they both will cause spontaneous ovulation, both type of drugs, and the third one is letrozole. Letrozole is even that is the best drug because that is associated with like 80% letrozole because that is associated with 80% chance of ovulation.
Ovulation. Okay.
So they are telling us that ovulation has occurred, but after that, what is the pregnancy rate? What is the live birth rate? Because we are using, these are just inducing ovulation. They have no way to ensure that this patient is going to have a live birth because fetal factors will come into. Even before fetus, the male factor will come into, uterine factor, tubal factors, many unknown factors, cervical factor, general health of the woman. So many things, they will have a complex interplay. That's why we cannot say. So basically, you need to remember that in how many patients taking clomiphene, the ovulation will take place, like 60 to 70%. Okay? And how many patients on GnRH they are going to ovulate, like 60 to 70%. That is the point. Okay. That is the point. Okay.
Yeah.
So
okay.
that's why the things that we don't know, yeah, we can miss them. But the guidance which has been given and the documents like that, there is like you will give preference to the green top guidelines and these nice guidelines. So the information which is provided, that should be on your fingertips. Okay. And besides that, if they test something, then that is your luck. Okay? Because for but there is always some answer. Like maybe they have answered this question in the TOG, maybe they have answered in the SIPs, That's why, the part 2 is very hard, very challenging, because the syllabus is so lengthy. That is the problem, okay?
Yeah.
Okay. So the unexplained infertility, ovarian stimulation for unexplained infertility. So we should not offer oral ovarian stimulation agents such as acromegaline citrate, anastrozole or letrozole to women with unexplained infertility. Unexplained means that we don't know the cause. So if we don't know the cause, then why we would be stimulating her? Because maybe she is already ovulating. So we need to inform women with unexplained infertility that the clomiphene citrate as a second line treatment, it doesn't increase the chances of pregnancy or a live birth. So we need to advise them that if they are having unprotected sexual intercourse, to try to conceive for a total of 2 years, in which 1 year they have been trying, and then in the second year we have carried out all investigations. And after like 2 years, like 1 year when we didn't start investigating and they were trying on their own, and next year we have spent in the investigations. Only after 2 years we should offer them like investigation, okay? And IVF should be after 1 year, offer them investigations, and after 2 years, offer them IVF. So offer IVF treatment to the women with unexplained infertility who have not conceived after 2 years, and this can include up to 1 year before their fertility investigations of regular unprotected sexual intercourse. Intrauterine insemination. You should consider unstimulated intrauterine insemination as a treatment option in the following groups as an alternative to vaginal sexual intercourse, like people who are unable to find it and unable to do, or they find it hard to have vaginal intercourse because of a clinically diagnosed physical psychosexual problem, who are using partner or the donor sperm, then we should offer them IUI. People with conditions that require specific consideration in relation to the method of the conception, like sperm washing, where the man is HIV positive. But this has been like challenged that it should not be washed, okay? But IUI, yes, we can do. So then IUI can be offered in the same sex couples. And for people who have not conceived after 6 cycles of the donor or the partner insemination despite evidence of normal ovulation, like there was tubal patency and Siemens Analysis, everything is fine, and the tubes are patent, then we can offer them a further 6 cycles of unstimulated intrauterine insemination before IVF is considered. For people with unexplained infertility, like they have mild endometriosis or mild male factor infertility who are having regular unprotected sexual intercourse, we can offer them IUI. Do not routinely offer intrauterine insemination either with or without ovarian stimulation. Like exceptional circumstances include, for example, when the people have social, cultural, or religious objections to the IVF. Advise them to try to conceive for a total of 2 years, and this can include up to 1 year before we started investigating them and before the IVF will be considered. Then prediction of the IVF success. The female age is the most important predictor of the IVF success. And as her age will increase, the chances of success of the IVF, they will decrease. Then what is the number of previous treatment cycles? We need to inform people that the overall chance of a live birth following the IVF treatment, it falls as the number of the unsuccessful cycles increases. Like in the first cycle she couldn't conceive, so the chance will decrease for the second cycle. In the second cycle she didn't conceive, then the chance will increase even for the third cycle that she will stay unpregnant. So previous pregnancy history. People should be informed that the IVF treatment is more effective in women who have previously been pregnant and they have given, like they had a live birth. Then the BMI is very important, that female BMI should be kept between 19 to 30 before commencing assisted reproduction, and it is likely to increase the success of the assisted reproduction procedures. Regarding lifestyle factors, more than 1 unit of the alcohol per day, it reduces the effectiveness of assisted reproduction procedures, including the IVF. Smoking can adversely affect the success rate of the assisted reproduction and procedure, including the IVF treatment. Caffeine consumption, it has had adverse effects on the success rate of assisted reproductive procedures, including IVF treatments. There are certain criteria for referral for the IVF, like discuss the risks and benefits of the IVF in accordance with current Human Fertilization Society guidelines. So inform the people that normally a full cycle of IVF with or without intracytoplasmic sperm injection, each should comprise one episode of ovarian stimulation and transfer of any resultant fresh and frozen embryo. Everything is going to be considered one cycle, right from stimulation to getting a frozen embryo. So in women aged under 40 years who have not conceived after 2 years of regular unprotected intercourse or 12 cycles of the artificial insemination, where six or more are by IUI, you will offer 3 full cycles of IVF with or without ICSI. So if the woman reaches the age of 40 during the treatment, we should complete the cycle and then we should not offer her any further cycle. So as you know that when you are offering this treatment on NHS, the couple, they have to maintain their BMI and then they should not be smokers, right? So if they are smoker or they are obese, then the cycle is withheld. It is not offered. So in a
But
woman,
are we still offering like routinely this?
yes, we are. We are still offering. So the list has been given above. Why? Because it is important. The patient has the right to get treatment, right? So there are always exceptions. Like one treatment is not for everyone. That's why we can offer them these treatments if their lifestyle demands. Okay. So, in women aged 40 to 42 who have not conceived after 2 years of regular unprotected intercourse or 12 cycles of artificial insemination, where 6 or more were IUI, then we are going to offer one full cycle of IVF with or without ICSI, provided the following 3 criteria are fulfilled. Now look at the age of the woman. She is between 40 to 42. So if they have never previously had IVF treatment, there is no evidence of low ovarian reserve, means no low FSH, no high FSH, no low AMH, and the follicular count is antral follicles. Their number is also good, more than 4. Okay. So when the investigation shows that there is no chance of pregnancy with expectant management and where the IVF is the only effective treatment, then refer the woman directly to the specialist team for IVF treatment when she is between 40 to 42. Why directly to the IVF treatment center? Because she needs help. The time will pass and then she will be unable to conceive. That's why we refer them early. And then in women aged under 40 years and IVF full cycle previously, whether it was self-financed or the NHS funded, they should count towards the total of the 3 full cycles. So consider the outcome of the previous IVF when assessing the likely effectiveness and the safety. Further IVF should be considered that it should be safe and effective or not. So it will predict that what is the chance of progress now. So a cancelled IVF cycle is one where an egg collection procedure is not undertaken. Cancelled is not one where we stop the drug. Cancelled is one where we didn't retrieve eggs. Eggs were not collected. Also SBA question. So once you have collected the eggs, it means that you have not cancelled the cycle, next cycle, okay? So a cancelled cycle due to low ovarian reserve, it should be taken into account when considering suitability for further IVF treatment. So then the procedures used in the IVF treatment, like there is some pre-treatment, then treatment, okay, and the post-treatment we support the growing embryo also. So pre-treatment means that we need to advise the woman that using pre-treatment with or either the oral contraceptives or the progesterone as part of the IVF, it doesn't affect the chance of having a live birth. Consider pre-treatment in order to schedule IVF treatment for women who are not undergoing long down regulation protocols. Down regulation and the other regimens to avoid premature LH surge in the IVF. We can do different things, like we can use different regimen. This is when we are trying to protect the patient from ovarian hyperstimulation. So use regimens to avoid premature LH surge in gonadotropin stimulated IVF treatment cycles. Use either GnRH agonist down regulation or gonadotropin releasing hormone antagonist as part of gonadotropin stimulated IVF treatment cycles. Only
Sorry, could you repeat
this one?
No, regarding the cancelled cycle IVF.
Down regulation and the other regimens to avoid premature LH surge in the IVF. So we can use regimen to avoid premature LH surge and in the gonadotropin stimulated IVF cycles, and we can use either gonadotropin releasing hormone agonist down regulation or gonadotropin hormone releasing hormone antagonist as a part of the GnRH stimulated IVF treatment cycle. So only we should offer GnRH hormone agonist to the woman who have a low risk of ovarian hyperstimulation syndrome. So when using gonadotropin releasing hormone agonist as part of the IVF treatment, we should use a long down regulation protocol. So down regulation means that we are going to give like the half dose, like 37.5 mg of the international units of the FSH. Okay, so that is how we are going to down regulate. What is the purpose of the down regulation? We want to render the LH FSH receptors more sensitive, more responsive, okay, to make them more responsive. Why? That's why we are going to give them a lower amount of the hormone. So when we are using gonadotropin releasing hormone,
just sometimes sometimes confuses me. Sometimes confuses me when we say we give the gonadotropin releasing hormone to stimulate the ovary, and then in another time we are giving it to to suppress the ovary.
Yes.
So
because
could you explain that to me? Because
sure. Like I said, that instead of giving the full dose, because you know how this system works, this system of the reproductive hormones. Okay, let me show you some pictures. Being is that in the hypothalamus, this is like paraventricular nucleus, then this is preoptic, and this is optic supraoptic nucleus. Okay, so these preoptic and the supraoptic in the hypothalamus, they will secrete gonadotropin releasing hormone. This GnRH then coming this greenish one, it goes and affects the anterior pituitary. So what happens here? It will stimulate will stimulate the gonadotropes. Then the pituitary is going to secrete LH and FSH. So these LH and FSH, like this is the luteinizing hormone going to the theca cells in the cervix. It will go in them, and it will increase the activity of the side chain cleavage enzyme just to yield the active substances. That is what it is doing. So what will happen in the ovaries? We have started with the progesterone, but we produced androstenedione and the testosterone. So these are secreted as the gonadotropins. So LH came to the theca cells, crossed the basement membranes, exerted its effects here, then it went to the other cells, and it causes formation of the other hormones like that. Like in the male, it can form like testosterone, and in the female, it will form estrone like that. Okay, that is one. But this action, like some actions that took place in the theca cells. In the ovaries, we have two types of cells, like the theca cells and the granulosa cells. In the theca cells, we are getting just LH, right? And in the these like the LH, we have receptors only for the LH. LH and FSH we are getting from the anterior pituitary. So LH inside the ovaries, it is going to produce testosterone, and it can also produce androstenedione. Then these cells, because the LH receptors are not present on the granulosa cells. On the granulosa cells, we have receptors only for the FSH. FSH is attached, so it will go inside, and this androstenedione, this granulosa cells, they cannot produce this androstenedione, so they will take the ready-made this androstenedione coming from the theca cells, and then by the action of the aromatase in the presence of the cyclic AMP, we are going to produce estrogen, and small amount of the testosterone is produced in the granulosa cell. So FSH, it basically activates the aromatase, and which will facilitate the formation of the estradiol. So all of these actions, like when these hormones are formed, then what happens? How do they control their own secretion? What will happen? Like from the ovaries, we had this progesterone, estrogen. They will go to the uterus, and they will cause like proliferative or the secretive changes, depending upon the phase of the cycle. But ovaries, what the ovaries are producing? Ovaries are producing just progesterone and estrogen. So these estrogen and progesterone, when we have enough amount of these hormones, they will go and they will exert negative feedback on the anterior pituitary as well as on the hypothalamus, to tell these places that there is enough amount of estrogen and progesterone in the system, and they don't need to produce more hormones. Is it clear? So that is how
Yes,
they are
yeah.
going to inhibit their own production like that. So that's why it is important that we should know about the problems, that how these things can occur. Okay, so that's why down regulation, like down regulation means that we are using the lowest amount of the FSH, because we don't give LH to stimulate ovulation, we give FSH, right? Like we are giving,
Yeah.
always giving the follicle drops and FSH like that. So they are going to produce more eggs. So we are down regulating means like we are stimulating the exciting the ovaries, but at a very low dose of the FSH. That is called down regulation. Like you must have seen that what the guidelines say is that when we are giving them FSH, so we can give them like even 4 injections can be given on daily basis. Okay. So each injection contains like 75 international units of the FSH. So then down regulation means that instead of giving these very high doses, we are going to stimulate the receptor with very low dose of the FSH. So instead of giving her like 300 or 450, you are going to give her only 37.5 mg. Okay, so you are trying to produce response with very low dose of the FSH. That is called down regulating the receptor. Is this point clear now?
Yes, yeah, clear.
And after the treatment, like after this down regulation for like 2-3 weeks, then we can again stimulate the ovaries at a higher dose like that. Okay, so it is
So
associated with better
basically, just
outcome.
down regulation
Yeah,
means we're starting with a small
yeah.
dose, low dose.
So
Okay.
and these are the long protocols. The short protocols, like we are giving to everyone, like you are giving clomiphene citrate from day 2 to 7 of the cycle. Remember things like that. That is the point.
Okay.
That is the point. Okay. So that is the short protocol, and the long protocol. We will talk about them. Long protocol when we are down regulating them, because it will take like more and more time. That is the point. Okay. So can we go to the next point, or we should come back? Is it clear now? The long protocol
Yeah,
and the short?
yes, yeah.
Okay.
So with the long one, we use the
Low
lowest
dose.
dose, and then with the okay.
The short one we are going to use higher dose. So controlled ovarian stimulation in the IVF. So we should use ovarian stimulation as part of the IVF treatment. So we can use either urinary or recombinant gonadotrophins for ovarian stimulation as part of the IVF treatment. So when we are using like when using gonadotrophins for ovarian stimulation in IVF treatments, then use an individual individualized starting dose of the follicle stimulating hormone based on factors that predict success, such as age, BMI, presence of PCOS, then ovarian reserve, and do not exceed the dose of a follicle stimulating hormone. The maximum dose is 450 international units per day. So we should offer ultrasound monitoring at least in the first cycle to look for the efficacy of the gonadotropes that they are stimulating. So what is the response of the ovaries? And then inform the woman that the clomiphene citrate stimulated and the gonadotropin stimulated IVF cycles, they have higher pregnancy rates than the natural cycle IVF. And do not natural cycle IVF, do not offer like you are doing this IVF cycle, so don't rely on the natural cycle. You need to stimulate. Whenever you see the word IVF, you should know that you have stimulated the ovaries, because you want to yield the maximum, get the maximum benefit for your patient, right? So that's why we will have to stimulate the ovaries. So don't use growth hormone or dihydroepiandrosterone as adjuvant treatment in IVF protocols. And then triggering ovulation. Offer women human chorionic gonadotropin like urinary or recombinant to trigger ovulation in IVF treatment. Offer ultrasound monitoring of the ovarian response as an integral part of the IVF treatment. And the clinics which are providing controlled ovarian stimulation with gonadotropin, they should have protocols in place for preventing, diagnosing, and managing ovarian hyperstimulation syndromes. So oocyte and the sperm retrieval in IVF. So women undergoing transvaginal retrieval of the oocyte, they should be offered conscious sedation because it is safe and acceptable method of providing analgesia. This safe practice of the administrating sedative drugs, it should be followed by retrieval of the eggs. This practice should be followed. And women who have developed at least 3 follicles before oocyte retrieval, they should not be offered follicle flushing because this procedure doesn't increase the number of the oocytes retrieved or pregnancy rates, and it increases the duration of oocyte retrieval and associated pain. So surgical sperm recovery before intracytoplasmic sperm injection, it may be performed using several different techniques depending upon the pathology and wishes of the men. In all cases, facilities for cryopreservation of spermatozoa, they should be available. Assisted hatching is not recommended because it has not been shown to improve pregnancy rates. So the embryo transfer and the strategies in the IVF, they are always asking you a question around this subject. So women undergoing IVF treatment, they should be offered ultrasound guided embryo transfer because this improves pregnancy rates. So replacement of the embryo into the uterine cavity when the endometrial thickness is less than 5 millimeter, then it is unlikely to result in pregnancy. So the minimum endometrial thickness should be 5 millimeter. So women should be informed that the bed rest of more than 20-minute duration following the embryo transfer, it doesn't improve the results of IVF treatment. The embryologist should evaluate embryology quality at both cleavage and the blastocyst stages according to the association of the clinical embryologist of the UK and the Europe. And then how many embryos should be transferred. So for the woman whose age is under 37 years, so the full IVF cycle, and we should use single embryo transfer. In the second full IVF cycle, we can use single embryo transfer if one or more top quality embryos are available. Consider using 2 embryos if no top quality embryos are available. And in the third IVF cycle, transfer no more than 2 embryos. Now, if the age of the woman is between 37 and 39, so in the first and the second full IVF cycle, use single embryo transfer if there are 1 or more top quality embryos. consider double embryo
Sorry,
transfer.
can I ask a
Sure,
question?
sure, why not? Problem. So if the age of the woman is between 37 to 39, so if the first and the second full IVF cycle, then you can use single embryo transfer. And if there are one or more top quality embryos are present, then we can give single embryo transfer because we have very good quality embryos. So you should consider double embryo transfer if there are no top quality embryos, like you are not very happy with the results and you have like acceptable embryos, then you are going to transfer two embryos, okay? And under no circumstances you can give more than two ova. More than two is not allowed, okay? So only two maximum should be given. You have top quality in this age group, give her one embryo. But if you don't have the top quality embryo, then give her one embryo, two embryos, okay? That is the point.
Yeah.
Okay, so and then in the age group 40 to 42, you will consider double embryo transfer right from the start because in view of her age, she is very likely to fail this IVF. That is the point. So for women undergoing IVF treatment with donor eggs, use an embryo transfer strategy that is based on the age of the donor. Age of the donor, not age of the recipient.
Yeah.
And no more than two embryos, they should be transferred during any one cycle of the IVF treatment. And where a top quality blastocyst is available, then you will use single embryo transfer. So when considering double embryo transfer, advise people for the risk of the multiple pregnancy associated with this strategy. So offer cryopreservation so that the remaining good quality embryos after the embryo transfer, they will be kept in the patient's account. So advise women who have regular ovulatory cycles that likelihood of a live birth after replacement of the frozen thawed embryos is similar for embryos which are replaced during natural cycle and the hormone supplemented cycle. Regarding the luteal phase 4 after the IVF treatment, that's why I said treatment before IVF, during IVF, and then after IVF. So luteal phase 4 after IVF. Offer women progesterone for luteal phase 4 after IVF treatment and don't routinely offer women human chorionic gonadotropin for luteal support after IVF treatment as increased risk of the ovarian hyperstimulation syndrome. Evidence doesn't support continuing any form of the treatment for luteal phase 4 beyond 8 weeks of gestation. Give for the gamete intracytoplasmic sperm transfer, zygotic transfer, so there is insufficient evidence for gamete intrafallopian transfer or zygote intrafallopian transfer over IVF in couples with unexplained fertility problems and male factor fertility problems. So then, what are the indications for intracytoplasmic sperm injections? Like recognized indications for the treatment of the ICSI includes there are severe deficits in the semen quality. Like I said before, that two or more parameters are abnormal, okay, as compared to the WHO standard.
Yes.
So then you will say that sperm it has like severe deficits. Then if there is obstructive azoospermia, then non-obstructive azoospermia. So all of these are the indications for ICSI. So in addition, the treatment by ICSI, it should be considered for couples in whom a previous IVF treatment cycle has resulted in failed or very poor fertilization. So the genetic issues and the counseling, and before considering treatment by ICSI, people they should undergo appropriate investigations both to establish the diagnosis and enable informed discussion about the implications of treatment. Before treatment by the ICSI, consideration should be given to relevant genetic issues. Where a specific genetic defect associated with male infertility is known or suspected, the couples they should be offered appropriate genetic counseling and testing. And where the indication for ICSI is severe deficit of the semen quality or non-obstructive azoospermia, the man's karyotype, it should be established. So men who are undergoing karyotype they are offered genetic counseling regarding the genetic abnormalities that may be detected. Testing for Y chromosome microdeletions, it should not be regarded as a routine investigation before ICSI. However, male infertility results from abnormalities of the gene on the Y chromosome involved in the regulation of the spermatogenesis, and the couples they should be informed of this. If we compare ICSI with the IVF, we should inform couples that ICSI improves fertilization rates compared to the IVF alone. But once fertilization has occurred, whether it was through ICSI or it was through IVF, both are the same. Then ICSI is not better than the IVF, but they are important for fertilization. Okay, that is the point. In cases of donor insemination, what are the indications for donor insemination? The use of donor insemination is considered effective in managing fertility problems associated with the following conditions, like there is obstructive azoospermia or non-obstructive azoospermia. There are severe deficits in the semen quality in couples who do not wish to undergo ICSI. Donor insemination should be considered in conditions such as where the risk of transmitting the genetic disorder to the offspring are there, and where there is high risk of transmitting infectious disease to the offspring or the woman from the man. Then severe rhesus isoimmunization. Regarding information and counseling, the couples they should be offered information about the relative merits of the ICSI and the donor insemination in a context that allows equal access to both treatment options. And the couples considering donor insemination, they should be offered counseling from someone who is independent of the treatment unit and regarding all the physical and the psychological implications of treatment for themselves and potential children. Screening of the sperm donors, units undertaking semen donors recruitment and the cryopreservation of the donor spermatozoa. For the treatment purpose, they should follow the UK guidelines, and there are special guidelines that they should not be having any genetic disorder. Age should not be more than 40 years, and they should not be suffering from any infectious disease. Okay. So the assessments that we need to offer to the woman before starting treatment by donor insemination confirm that the woman is ovulating. Women with a history that is suggestive of the tubal damage, they should be offered tubal assessment before treatment. Women with no history of the tubal disease, they should be offered tubal assessment after 3 cycles of the treatment by the donor insemination. So if we are doing this donor insemination, it should be intrauterine or it should be like intravaginal or intracervical. So offer intrauterine insemination in preference to the intracervical because it is associated with better outcomes, better pregnancy rate. So intrauterine insemination is important. Where intrauterine insemination is important as compared to the intracervical insemination. Unstimulated versus stimulated donor insemination. Women who are ovulating regularly, they should be offered a minimum of 6 cycles of donor insemination without ovarian stimulation to reduce the risk of multiple pregnancy and its consequences. Oocyte donation, in which conditions you can donate the eggs. So the use of donor oocytes is considered effective in managing fertility problems associated with the following conditions, like premature ovarian failure.
Can I ask you just to go back to
that if you have assessed the woman and she is ovulating, just like IUI. In IUI also you can offer them 6 cycles, okay? So here she's not being inseminated with the partners in semen and she is just receiving donors semen.
Okay.
So that
Okay.
is the only difference, okay? But still,
Okay.
we will give it to her for 6 cycles. That is what it says.
Okay.
Then regarding the ovum oocyte donation, what are the indications for oocyte donation? So these are the indications, like who should be given, who should receive this one, who should receive this egg donation? The one who had premature ovarian insufficiency, the one with gonadal dysgenesis, including those with the Turner syndrome. Then those who have undergone bilateral oophorectomy, then ovarian failure following chemotherapy or radiotherapy. Then in certain cases of IVF treatment failure. So oocyte donation, it should also be considered in certain cases where there is a high risk of transmitting a genetic disorder to the offsprings. So regarding screening for the oocyte donors, before donation is undertaken, oocyte donors, they should be screened for both infectious and the genetic diseases in accordance with the UK's regulatory guidance. So basically we need to exclude genetic disorders and then infective disorders. So
Yeah.
oocyte donation and egg sharing. So oocyte donors, they should be offered information regarding the potential risk of ovarian stimulation and oocyte collection. A third party should counsel oocyte recipient and donors on physical and the psychological implications of the treatment for themselves and their genetic children, including all potential children from the donated oocytes. So all people considering an egg sharing scheme, they should be counseled about its particular implications. And special, you will have to think about the people like who are undergoing this cancer treatment and they wish
Cancer.
to retain fertility. So cryopreservation of the semen, cryopreservation of the oocyte, cryopreservation of the embryos, and then regarding this cryopreservation of the semen, oocyte, and the embryos. So when we are considering cryopreservation before starting chemo or radio, that is likely to affect their fertility. So we need to follow standard guidelines. Then at diagnosis, the impact of cancer and its treatment on the future fertility, it should be discussed between the person diagnosed with cancer and their cancer team, because it will be unethical, because if this person is going to die after producing children, then it will not be a good idea, because these children, they should not grow up without a guardian. At diagnosis, everything should be discussed with the cancer team. So when deciding to offer fertility preservation to people like who are diagnosed with cancer, we should take into account the following factors: diagnosis, their treatment plan, expected outcome of subsequent fertility treatment, prognosis for the cancer treatment, viability of the stored or the post-thawed material, and then for cancer related fertility preservation, do not apply the eligibility criteria used for conventional infertility treatment. Do not use a lower age limit for cryopreservation for fertility preservation in people diagnosed with cancer. Inform people diagnosed with cancer that the eligibility criteria used in conventional infertility treatment, they do not apply the cause of they don't apply in the case of the fertility cryopreservation provided by the NHS. However, those criteria, they will apply when it comes to using stored material for assisted conception in an NHS setting. So when using the cryopreservation to preserve fertility in people diagnosed with a cancer treatment, the sperm, embryos or the oocyte, we should follow the standard guidelines. So offer sperm cryopreservation to men and adolescent boys who are preparing for the medical treatment of the cancer that is likely to make them infertile. Then use freezing in liquid nitrogen vapors as the preferred cryopreservation technique for the sperms. Once they asked this in the SBAs and people were angry because they don't read the guidelines in depth, but this is given in the guideline. Okay, so we are going to use uh,
Freezing.
freeze them in the liquid nitrogen. Okay, Then offer oocyte or the embryo cryopreservation, and this is the treatment for the cancer that is likely to make them infertile. If they are well enough to undergo ovarian stimulation and egg collection, and this will not worsen their condition, and enough time is available before the start of their cancer treatment. So the cryopreservation of the oocytes and the embryos, we can use the vitrification instead of the controlled rate freezing if the necessary equipment and expertise is available. So then the store cryopreserved material for an initial period of 10 years. Okay, so offer continued storage of cryopreserved sperm beyond 10 years to the men who remain at risk of significant infertility. So like if the side effects of the drugs are like very long lasting, then you will have to increase the duration for which the sperms are frozen. But usually the sperms are frozen for 10 years. So
10 years.
exceptions they are always making like that. Okay.
Okay. What was the question regarding the freezing the liquidity?
Yeah. Which method you are going to use to freeze the sperms? So liquid nitrogen. Okay. That was the SPA. Okay. So what is long-term safety of ART for women with infertility and their children? So long-term health outcomes of ovulation induction and the ovarian stimulation. So we should give people who are considering ovulation induction or ovarian stimulation up-to-date information about the long-term health outcomes of their treatment. Give them written information. You can give them video links, the support group. Inform women who are offered ovulation induction or ovarian stimulation that no direct association has been found between the treatments and invasive cancers, and no association has been found in the short to the medium term between the treatment and the adverse outcomes, including the cancers in children born from the treatment. So they are totally unaffected. Okay. Then information about the long-term health outcomes in women and the children is still awaited. And limit the use of ovulation induction or ovarian stimulation agents to the lowest effective dose and the duration of use. Regarding long-term health outcomes and safety of IVF, give people who are considering IVF treatment with or without ICSI, give them up-to-date information about the long-term health outcomes, including the consequences of multiple pregnancy of these treatments. And we have to tell them that these things like cannot be excluded, that what will happen in the long run. But in the short term, we know that these procedures are not associated with any problems like that. So that's all we need to know about the fertility problems according to the NICE guide.